handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi. So, welcome again to our OSI, Organ System Integration. This time it's part 2 for Renal. So, that's Patho, Pharma, and Micro. Anyway, so I want to re-emphasize this. This is the testing effect. So, our OSI is question-based. So, we will answer questions. This is because of the testing effect that if you too long didn't read TLDR, if you study by testing, you retain more information versus studying conventionally, rereading, highlighting, summarizing, etc. So we want to take advantage of that advantage of that of that advantage. So that's it, no? So the testing effect or learning through testing is actually retrieval practice. So I want to my favorite analogy with this is for instance, training for a sporting event or rehearsing for a performance. So if you are going to play basketball, for instance, for example, how do you train? Diba, you play basketball, you train playing basketball. So in a band rehearsal, if you're a guitarist, how do you train? Diba, you play the guitar. Now, in exams, in answering questions, because our final endpoint is the boards, we will answer questions. How do we train? We answer questions. Alright? So, meron akong I want to emphasize yung phase 1 and phase 2 of learning. That phase 1 is getting the knowledge into our heads. Phase 2, knowledge from our heads to the paper, or kung ano man yan, if you're going practical, from our heads to your practicals, whichever fits the situation. Anyway, so that's a short introduction. And let's start. So, anyway, this is pathology. Hindi ko nasabi kanina that these questions would be fairly challenging. Okay? It's okay. It's okay to answer these questions wrong. If you answer these questions right, it's okay. Very good. But the most important part is that we will rationalize it. So yun. So these questions are fairly challenging, but for a reason, for a very very good reason. Okay? To stimulate our heads. Okay? So grab your coffees. Kung nagkakape kayo, kung hindi, okay lang. Kung ano yung form of stimulation na gusto nyo, it's fine. Whichever floats your boat, no? Anyway, I've been talking for 5 minutes straight. And let's start, no? Let's start our pathology, renal pathology. So, let's start with our first question. Now, first question, okay? Relax, okay? 6-year-old female. Let's underline the important parts, okay? 6-year-old female presents with dark red urine, okay? Dark red urine for 3 days in duration, okay? Now, this patient was treated for impetigo, okay? Treated for impetigo 5 weeks ago. Okay, significant yung BP niya for 140/90. Urinalysis, hematuria. mild proteinuria, and RBC casts. So at this point, I think meron na tayong diagnosis in mind. Okay, now which of the following is expected on renal biopsy if you were to do a renal biopsy to this patient? Okay, so what do you think? What do you think is happening to this patient? So with the history alone, no, treated for impetigo 5 weeks ago. So tapos nagkaroon siya ng hematuria. What do you think? So this is in the branch of your nephritic syndrome, no? I think this is your PSGN or your post-streptococcal glomerulonephritis, and that's because no nag-impetigo siya 5 weeks ago. Usually kapag impetigo, your skin, no, skin infections, pero mga 4 weeks yan, no, 4 weeks. Pero kapag mga strep throat, usually 2 weeks lang yan. Okay? Now, this patient has nephritic syndrome. May hypertension, mild proteinuria, RBC casts sa urine sediment. So, yun ha. Skin infection, post-strep talaga. PSGN talaga yung pinag-uusapan natin dito. And that's actually, this is high yield. Okay, take note. This is the most common cause of nephritic syndrome in children. Okay, PSGN is the most common cause of nephritic syndrome in children. Okay, now, PSGN, pathophysiology. PSGN is an immune complex mediated. Ano ang immune complex? Anong type? That's type 3 reaction, okay? Immune complex mediated. That occurs, siguro yun nga, sabi ko kanina, 2 to 4 weeks after exposure sa, this is the pathogen, no? Group A, beta hemolytic streptococcus. Okay? Anyway, there are antigens expressed on these nephritogenic streptococcal species. Tapos magko-combine siya with antibodies to form your immune complexes. Then, those immune complexes will then be deposited on the glomerular basement membrane. Now, you take a biopsy. Tinignan mo sa microscope, light microscopy. You will see in PSGN that all glomeruli are enlarged. Okay? Enlarged and hypercellular due to leukocyte infiltration and proliferation of your endothelial and mesenchymal cells. Basically, namamaga, no, yung glomerulus. It makes sense. Nephritic syndrome, this is glomerulonephritis. Nephritis, itis, maga. Diba? Anyway, if you do an electron microscopy, no, let's go deeper, let's go more magnification, no, electron microscopy, you will see electron dense deposits, also known as your humps, no, electron dense deposits or humps on the subepithelial side of the glomerular basement membrane. That's actually the answer, no, subepithelial humps on electron microscopy. Okay? Now, if you were to do immunofluorescence, this will reveal your coarse granular deposits of IgG, no? Tapos ang appearance niya would be your lumpy bumpy. So, I think that's clear, no, with PSGN. Okay? Now, we have different pathological findings in nephritic syndrome. Okay? So, yung mga iba't ibang klase ng nephritic syndrome would be your post-strep, post-strep glomerulonephritis or PSGN. So, anti-GBM disease, RPGN or rapidly progressive glomerulonephritis, IgA nephropathy, which is actually the most common nephritic syndrome overall. Okay? And Alport syndrome, no? Alport syndrome. So, there are different, no, mechanisms. So, iba't iba yung mechanisms sila of glomerular injury. Now, in post-strep, pinag-usapan natin kanina, immune complexes, di ba? Antibodies, antigens dun sa nephritogenic strain mag-react with our antibodies, immune complexes, dikit sa GBM nephritis. That's your PSGN. In anti-GBM disease, it's your antibodies against type 4 collagen. Direkta no, autoimmune, direkta. You have your antibodies, masama agad yung antibodies. Atakihin niya agad yung type 4 collagen in your GBM. In your RPGN, okay, this is a severe immunologic injury. Okay? Pwede siyang anti-GBM antibodies, pwedeng immune complexes. Okay? IgA nephropathy, from the name itself, IgA containing complexes. Now, Alport syndrome, in anti-GBM disease, your type 4 collagen is okay. Is normal, but inaatake siya ng antibodies. But in Alport syndrome, the collagen itself, initially, no, baseline, sira agad. Kasi defective agad siya sa Alport syndrome. Okay? Alport syndrome, type 4 collagen. Okay? Alport syndrome. Ayos ba? So, different nephritic syndromes, different biopsy features, and this is high yield. Okay? Different biopsy features. This is very high yield. Okay? Immunofluorescence for your post-rep, no? Ito yung granular staining, okay, of your GBM or your glomerular basement membrane. Electron microscopy, subepithelial humps. Take note, that's very high yield. Subepithelial humps, okay, for your PSGN. Your anti-GBM disease, take note of this, ha. Pwede siya may crescents, no, sa light microscopy, but in immunofluorescence, take note of this linear staining. Okay? Linear staining, that's your anti-GBM disease. Okay? Rapidly progressive glomerulonephritis, dito papasok yung crescents talaga. No? When you see crescents, no, in a question stem, think RPGN. Although sabi dito anti-GBM disease pwede magkaroon ng crescents, pero no. Test taking strategy, if you see crescents, think RPGN. Okay? IgA nephropathy, definitely ang problema natin is your mesengyum. Okay? So, if you will see mesangial hypercellularity in light microscopy, but in immunofluorescence, IgA in your mesangium. It makes sense, di ba? IgA. Kasi IgA, di ba? So, yon. Anyway, Alport syndrome, electron microscopy is your lamellated appearance. Okay? This is very high yield. Okay? So, I think we're okay with our PSGN and other nephritic syndromes, an overview at least, no? And we answered a question, no? So, we are training. Okay, so let's move on to our next question in our pathology. This is a 28-year-old male that presents with 3-month history of weakness and headaches. Let's underline that. P is significant for hypertension, 200/100. Normal yung heart rate, okay? Serum potassium of 2.7. This is high or low? This is low, no? Normal natin ang serum potassium is 3.5 to 5. Okay? Tapos, elevated plasma renin activity. So, PRA. Plasma renin activity is PRA. And serum aldosterone. Aldosterone is also elevated. Now, you do a 24-hour urine collection, you have an increased potassium excretion. Makes sense, di ba? Mababa yung potassium sa serum kasi mataas yung excretion ng potassium sa ihi. Now, what is the most likely etiology of this patient's condition? Now, this patient has elevated serum aldosterone. Elevated serum aldosterone. This is important. Now, this is a known cause of your hypertension. Kapag mataas ang serum aldosterone mo. Remember your RAAS? Okay, pag tumaas ang serum aldosterone, tataas ang BP, hypertension. Ano pang pwede? Pag mataas ang aldosterone, you will have hypokalemia. No? Hypokalemia if you have increased aldosterone. Okay? Now, with hypokalemia, you will have muscle weakness. Okay? Now, in the context of increased aldosterone, this is hyperaldosteronism. Okay? Hyperaldosteronism. Let's write that. Hyperaldosteronism. Okay? And this can be divided into primary and secondary etiologies. So, pwede siya maging primary or secondary. Okay? Now, in primary hyperaldosteronism, This is also known as your Con syndrome. Okay? Con syndrome. Ang pag-primary, ibig sabihin, you are secreting aldosterone from another site. And this is more often than not an adrenal adenoma or a bilateral adrenal hyperplasia. Okay, pwedeng adrenal adenoma, pwedeng bilateral adrenal hyperplasia. Basically, your adrenal glands are making more aldosterone than usual. That's primary, no? Primary. Kasi sa adrenal glands na po-produce ang aldosterone originally, di ba? Now, if you ramp that up in the presence of adenoma, in the presence of hyperplasia, that's primary hyperaldosteronism. Okay? So, ayun, no? That causes excessive and unchecked aldosterone production. Ano mangyayari pag sobrang dami mong aldosterone? Okay, sobrang dami mong aldosterone, you will have feedback inhibition. Okay? Raas pa din tayo. Ang dami mong renin, angiotensin, aldosterone. Ang dami mong aldosterone, what will happen to renin? No. You will have feedback inhibition of your renin. So, you will have decreased renin. Is this consistent with our case? Elevated plasma renin? So, mukhang hindi primary, no? Mukhang hindi primary yung hyperaldosteronism natin. Anyway, okay yung renin, okay, elevated plasma renin, and zero aldosterone tayo. So anyway, let's go back to primary hyperaldosteronism. Yun, to reiterate, it can be excluded in this patient because your plasma renin is elevated. Okay? Elevated plasma renin. So, definite, mukhang hindi tayo primary. Okay? So, let's look at secondary hyperaldosteronism. Pag secondary hyperaldosteronism, this is overproduction of your aldosterone, okay, that occurs secondary to increased renin synthesis. Okay? So, ibig sabihin, yung adrenal glands mo is just chilling. Okay lang yan, no? Walang problema in aldosterone production. But, the first in line sa RAAS, the renin, pinupush si adrenal glands mo to produce more aldosterone. That's secondary. Okay? Secondary hyperaldosteronism. Okay? So, we have different causes of your secondary hyperaldosteronism. So, we have, okay, renal artery stenosis. Okay? Lagi ko na lang RAS, pero this is not RAAS, this is renal artery stenosis. So, in renal artery stenosis, usually associated yan with fibromuscular dysplasia. This is usually sa young adult na women, no? Fibromuscular dysplasia or atherosclerosis sa older men, no? Sclerosis. Okay? Ano pang pwede for secondary hyperaldosteronism? Diuretic use. Okay, diuretic use. Bakit? Diuretic use, lalo na pag hindi indicated, no? Bababa BP mo. Anong mangyayari pag bumaba BP? Tataas ang renin. Di ba? Masasense ng kidneys yon na bumaba yung BP. Tataas ang renin, tataas ang aldosterone, ibabalik niya yung BP. That's physiology. Now, if you use diuretics, you will have an increased renin and increased aldosterone. That's actually physiologic. No? Ano pa? Malignant hypertension. Okay? Okay, malignant hypertension can lead to microvascular damage and renal ischemia. And ito, last, renin secreting tumors. Okay? Renin-secreting tumors. It makes sense, no? Reninomas, no? Reninomas yung another name. It makes sense. Meron kang renin-secreting tumor. Anong gagawin ni renin? Papataasin niya si aldosterone. Itataas niya si aldosterone, mag-hypertension yung patient, mag-hypokalemia yung patient. No? So anyway, these renin secreting tumors are actually rare. No, rare, they are small, they are solitary, they are benign, no? And these are juxtaglomerular cell neoplasms, no? Remember that your renin is secreted by your juxtaglomerular cells. And that's actually the answer to this question. Juxtaglomerular cell tumors. So, if you are in a patient with marked hyperreninemia or elevated plasma renin activity and hypertension na mukhang walang renovascular disease, in this patient 28 male, if 28 female yan siguro, let's consider fibromuscular dysplasia. If that's a 40-year-old male or 45-year-old male, let's consider atherosclerosis for the renal artery stenosis. But in this patient na mukhang hindi siya renovascular, let's consider renin secreting neoplasms. Although again, no, this is rare. So, yun ha. Secondary hyperaldosteronism. Okay, so, ayun. So, again, if hypokalemic hypertension, check your PRA or your plasma renin activity. If it's high, that's almost always, no, secondary hyperaldosteronism. Okay, kasi yung renin yung nagpapa-hyperaldosteronism. Yung renin yung nagra-ramp up ng inyong aldosterone. That's secondary agad, no? So yun yung pinag-usapan natin kanina, no, yung mga causes of your secondary hyperaldosteronism. Okay? Pag low ang ating plasma renin activity, so mukhang primary to, no? Mukhang primary to. Okay? So check your aldosterone. Okay, if PAC, PRA more than 20, that's primary hyperaldosteronism. That's a topic for another day. I think this will be covered in your internal medicine or already covered in internal medicine. Okay, if aldosterone is low pero meron kang hypokalemia with hypertension, let's look at other causes, no? Let's look at other causes. Cushing's, congenital adrenal hyperplasia, etc. No? So, mukhang hindi sa raas yung problema kapag ganon. Kapag low and low. Okay? Pag low and high, low renin, high aldosterone, think of primary hyperaldosteronism. So, again, ano yung mag-cause ng primary hyperaldosteronism? Manggagaling mismo sa adrenal glands, tumors, no? Adrenal adenoma or bilateral adrenal hyperplasia. Alright? So, let's move on, no, to our next question. I think that's clear. No? Clear tayo with our aldosterone. Okay? So, ayun. Next question. This is a 2-year-old male that presents with failure to thrive and polyuria. Let's underline that. Okay? Failure to thrive and polyuria. You did a urinalysis. Meron tayong glucosuria. But our serum glucose is within normal range. Okay, now what is the most probable renal pathology for this patient's condition? Okay? Now, glucose, bicarbonate, amino acids, calcium, phosphate, they are normally filtered by your glomerulus. Okay? And they are reabsorbed by your proximal tubule. Okay? These are important. Sorry. GERD. These are important electrolytes. Okay? So, pag important electrolytes yan, definitely gusto ng katawan yan ibalik sa katawan. No? So, reabsorb sila proximal tubule pa lang. Now. When your proximal tubular transport is defective, for instance, in Fanconi syndrome. Fanconi syndrome is different from Fanconi anemia, ha? Okay? Fanconi syndrome. That's different different from Fanconi anemia, no? Anyway, proximal tubular defect in Fanconi syndrome. Yung mga substances na sinabi ko kanina, amino acids, glucose, calcium, etc., this will appear in the urine, no? Pero in the serum, they are normal. Okay, that's your Fanconi syndrome, proximal tubule defect. Mukhang Fanconi syndrome, no? Patient. May glucosuria, hindi ma-absorb yung glucose, pero normal yung glucose sa serum. Okay? We have classic signs and symptoms of your Fanconi syndrome. That's actually because of the loss of your various substances in the urine, yung mga sinabi natin kanina. Fanconi syndrome, inheritance, this is autosomal dominant. Okay? Autosomal dominant, pwede din siyang autosomal recessive, pwede din siyang X-link. Basically, kahit ano. Okay? So, clinical manifestations, polyuria, polydipsia, failure to thrive. Consistent? Yes, no? Usually, those symptoms tend to occur sa first years ng life ng patients with Fanconi syndrome, just like in this patient. No? Increased calcium loss. Pinag-usapan natin that calcium is also reabsorbed in your proximal tubule. You will have calcium mobilization from the bones. So, ang problema, the body wants to maintain a certain level of normal calcium, no? Certain normal level of calcium. But if your kidneys constantly excrete your calcium kasi hindi siya ma-reabsorb, hindi pwede yun. Sabihin ng body mo, hindi pwede na mababa yung calcium natin. We have to tap into our calcium reserves. And the largest calcium reserves ng ating katawan is your bones. Okay? And kapag we mobilize calcium from the bones in a child, no, that can cause severe rickets. Okay? So Fanconi syndrome can also cause severe rickets. Although if exam-wise, no, if we are talking about exams, test taking, if you see rickets, think vitamin D deficiency. But it's nice to know that Fanconi syndrome can also cause rickets. Okay? Now, ano mangyayari? Fanconi syndrome. Fanconi syndrome, hindi mo ma-absorb yung calcium, ini-excrete mo. Ang dami mong calcium sa ihi. That's hypercalciuria. Now, if madami kang calcium sa ihi, that will predispose you to nephrolithiasis. Okay? Kidney stones din. So, ano na yung mga pinapag-usapan natin? Failure to thrive, rickets, nephrolithiasis, mga Fanconi syndrome, mga important in your Fanconi syndrome. Now, glucosuria. Pag-usapan natin yung patient. Glucosuria. In glucosuria and another one is low urinary pH, no? Low urinary pH. Remember that pwede rin mag-lower yung pH in Fanconi syndrome, no? Although not the main mechanism. Anyway, those can trigger frequent and severe urinary tract infections. Your bacteria love your glucose, no? So, ayun. Now, in a full case, no, urinalysis, that you will have presence of glucose, amino acids, bicarbonate, calcium, and phosphate, because those are the substances normally absorbed in your proximal tubule. Okay? So, if you do labs, no, serum sa patient, you can see hypokalemia kasi you are losing potassium. You can also see metabolic acidosis because you're losing bicarbonate. So, this is letter D, no? Defect in normal proximal tubular reabsorption because this is Fanconi syndrome. Okay? So, this is I think, BC, no? BC yung table niya about Fanconi syndrome. You can pause, no? You can pause. Read saglit lang, mabilis, then let's move on to the next question. Okay? So, this is your Fanconi, no? Fanconi syndrome. Okay? So, PCT defects. So, we discussed lahat naman kanina. So, I think that's clear, no? So, let's move on to the next question. Now, we have a 20-year-old female presenting with gross hematuria. Okay? I'm just checking if my mic is working. Okay, sorry. Now, anyway, this patient is type 1 diabetic. This patient is on insulin, good compliance. Okay? Type 1 diabetic, insulin, good compliance. unremarkable yung physical examination. Basically, just gross hematuria. Okay? Labs, backfilled RBCs on urinalysis. Normal serum complement levels. Now, what is the most likely diagnosis? Okay? Now, if we are gonna implement test-taking strategies sa ganito, fairly young, nagpe-present ng gross hematuria, siguro, tapos diabetic, hindi ko muna isipin yung diabetic, iisipin ko muna dito, siguro UTI, di ba? UTI. Pero I think hindi tayo if you look at the choices, we are not being hindi tayo pinapapunta sa UTI, no? So pinapapunta tayo sa mga different nephritis or different nephritic syndromes, no? Now, with this kind of vignette, okay, ay siguro isipin ko muna yung most common cause of your nephritic syndrome. Wala naman tayong dito, no? Wala namang history of skin infection, history of throat infection. Now, we discussed earlier what is the most common nephritic syndrome overall. That's actually IgA nephropathy. Okay? So, let's set that aside for a while. Most common cause, IgA nephropathy. Kasi that's more often than not, kapag ganito yung question stem, we are looking for the most common, no? Kapag wala masyadong clues na magro-rule in ng ibang causes of nephritic syndrome, usually yung mga most common na yan. Okay? Nephritic. IgA nephropathy. Okay? Pero let's set that aside for a while, no? So, we discussed earlier that nephritic syndrome, no? It makes sense. Nephritic, glomerulonephritis, itis, inflammation. So, inflammation of your glomerulus. Now, if your glomerulus is inflamed, you will have hematuria. Okay? Hematuria. Tapos, you will have RBC casts. Okay? RBC casts. Kasi galing sa glomerulus. Okay? Ano na? Tawag doon? Pisa na ang iyong red blood cells. That's how I remember it. Pisa na ang ating red blood cells sa glomerulus. Okay? Now, in patients with any kind of glomerulonephritis, we can see some form of renal dysfunctions like azotemia, uremia, not really, no, azotemia. We can see hypertension. They are really common, but in early disease or early in the disease process, they may not be present. Okay, hypertension and azotemia, not really uremia, no. Uremia may symptoms na agad yan. Okay? Anyway, patients may also have mild to moderate proteinuria. Remember our first case, may mild proteinuria siya, may PSGN siya. You can have edema, okay? But this is usually not as severe as in nephrotic syndrome. Nephrotic, basically you're losing a lot of protein in the urine. That's nephrotic, no? I remember nephrotic syndrome as protein losing kasi nephrothy, 'di ba? Pag frothy yung urine, we are associating that sa proteinuria, frothy urine. Proteinuria, nephrotic syndrome. Di ba? Okay naman, no? It's a good memory aid, no? It's a good memory aid. I still use that until now, no? Now, again, the most common cause of your nephritic syndrome overall is immune complex deposition. And most immune complex related nephritic syndrome, no? PSGN, MPGN, proliferative glomerulonephritis, and lupus nephritis. They are associated with IgG or IgM complexes, and meron silang heavy glomerular complement deposition. So, in those disease processes, your serum complement would be low, no? Hypocomplementemia. In this patient, normal ang ating serum complement levels. Again, kapag mga PSGN, MPGN, that's very hard to pronounce. Membranoproliferative glomerulonephritis or lupus nephritis, usually we have hypocomplementemia. So mababa ang complement levels because the complement the complement is being deposited. It's being consumed, no? It's being consumed. But in IgA nephropathy, that is typically associated with your normal serum complement levels. Okay? Normal serum complement levels. In this patient, normal yung serum complement level niya. So, mukhang we are leaning towards IgA nephropathy. Okay? And that's actually the answer to this question. This is IgA nephropathy. Okay? So, this is likely due to the weak complement fixing activity of your IgA compared to IgE and IgG and IgM, no? So weaker yung complement fixing activity ng ating IgA. Anyway, this is IgA nephropathy. Let's talk about IgA nephropathy. Okay? Now, IgA nephropathy is characterized as recurrent gross hematuria that typically occurs spontaneously, no? Spontaneously, parang tong pasyente na to. Or within 5 to 7 days of an upper respiratory or pharyngeal infection. So, in question stems pertaining to IgA nephropathy, usually that's versus PSGN, maglalagay ng history of infection, no? So in this, let's customize the case. 20 female presents with gross hematuria. Now this patient had a respiratory infections 5 days ago, no? So papaisip ka, infection o nagka-infection o baka PSGN. But the game changer here is the duration, no? Kailan siya nagkaroon ng infection? If just 1 week, no, tapos nag-gross hematuria siya, unlikely na PSGN yan. Pero if skin infection or throat infection na 2 to 4 weeks bago nag-gross hematuria, so most likely PSGN yan. Pero pag 1 week lang, 5 days lang, most likely that's IgA nephropathy. Now, when IgA nephropathy is accompanied by extrarenal symptoms, for instance, you have IgA nephropathy, but you have abdominal pain, you have arthralgias, you have skin purpura, that is known as your Schonlein purpura. Okay? When again, no, this is very high yield and very fun, no, very fun, high yield and very fun. When IgA nephropathy is accompanied by extrarenal symptoms. In a patient, no, meron kang IgA nephropathy, ganyan, nag-gross hematuria, pero normal yung serum complement. Tapos, meron siyang abdominal pain, meron siyang joint pains, meron siyang purpura. No, meron siyang purpura. That is known as your Schonlein purpura. Okay? IgA, mga IgA, ano yan? Mga IgA-mediated conditions or pathologies. Okay? Very good figure, no? Very good figure of your healthy glomerular filtration barrier, no? And you have nephritic syndromes here. You have mixed, no, nephritic and nephrotic syndrome, no? And these are some manifestations. Okay? So, nephritic syndromes, the most common, IgA nephropathy. I think we're good on that, no? So, let's move on. So, this is mahaba yung question. When I was studying, when I was studying for the boards, when I see these kinds of questions, niisip ko, di naman lalabas sa boards yung mga ganyan. I couldn't be any more wrong dun sa ganong assumption, because there are questions in the boards that are very designed to fatigue you, designed to give you more fatigue, to fatigue your eyes. They are designed para pagurin kayo, and to be prepared sa mga ganong klaseng kalaban. I see sa mga ganong enemies. Think of yourself as a soldier. To be prepared sa mga ganong klaseng enemies, we will train as early as now. Okay? So anyway, very long question to. 45 male presents with hematuria and nasal congestion. Now, physical examination, you have edema around the ankles, hands, and face. Okay? Now, you did labs. We have a BUN of 40 and a serum creatinine of 4.0. Elevated, no? Elevated. Abnormal. No, urinalysis, moderate proteinuria, backfilled RBCs, RBC casts. So, I think we are still in the lines of your nephritic syndromes here. No, nephritic syndromes are very high yield. Okay? You did a kidney biopsy. Meron kang cellular proliferation, focal necrosis, and boom, crescent formation. Buzzword, RPGN. Do you think this is RPGN? Let's see. No? Let's see. Anyway, when you did an immunofluorescent microscopy, you have no immunoglobulin or complement deposits. So, mukhang RPGN pa din ba? Pwedeng hindi. Okay? Pwedeng hindi siya RPGN. Kasi remember that RPGN usually may immunoglobulin deposits or complement deposits or immune complex, no? So, let's just set aside yung RPGN, pero may crescent formation ka pa din. Okay? Pero, this again, no, this still might be RPGN. No, this still might be RPGN. Okay? Anyway, which of the following additional findings? Now, we're looking for additional findings. So, we must know the diagnosis of this patient first, and we must know kung ano yung mga general findings in that diagnosis. Kung ano yung mga additional findings that is most likely present in this patient. Okay? So, we are dealing with a multiple step question here. Okay? Again, to reiterate, crescent formation is on light microscopy, that's indicative of your RPGN. Okay? What is RPGN? This is a syndrome of severe glomerular injury and that rapidly, no, kaya nga RPGN, rapidly progressive. This rapidly progresses to renal failure within weeks to months of onset. Okay? This can be caused by several different diseases. And these different diseases can be classified on the basis of immunologic findings. Okay? So, definitely this is RPGN. Tama tayo. This is RPGN. But we have to be more specific. We have to be more specific because we have to classify anong klaseng RPGN to. Okay? Anti-GBM na RPGN, anti-glomerular basement membrane. Let's write that down. Anti-GBM. Okay? In anti-GBM RPGN, the immunofluorescent findings would be linear. Okay? Linear GBM deposit. Well, GBM is glomerular basement membrane, ha? Linear GBM deposits of IgG and complement C3. C3 na lang, no? That will be found in your immunofluorescence. So, linear. Okay? This is linear. Linear. Okay? Now, in some patients, your anti-GBM antibodies or anti-glomerular basement membrane antibodies can cross-react with your pulmonary alveolar basement membrane. That can produce pulmonary hemorrhages. And may condition tayo doon. May disease tayo doon. Yung anti-GBM antibodies mo sa kidney, tumama rin sa lungs. That's your good pasture syndrome. So, good pasture. Okay? Good pasture. Glomerulus and pulmonary. Good pasture. So, that's another, kasakop siya ng anti-GBM disease or anti-GBM antibodies natin. Okay, another RPGN, another form is immune complex. RPGN. So, in immune complex, the buzzword is lumpy, bumpy. Okay? Lumpy, bumpy, granular pattern of staining for both antibodies. No? IgG, IgA may complement din in immunofluorescent microscopy. Now, your immune complex, RPGN, can be a complication of your post-strep glomerulonephritis or PSGN, can be a complication of your lupus, no, SLE. It can be a complication of your IgA nephropathy or kapag merong extrarenal symptoms, HSP or henoch-Schönlein purpura. Lastly, we have your POSI or POSI immune, RPGN. Now, in POSI immune, RPGN, there are no immunoglobulin or complement deposits on the basement membrane. So, this is POSI RPGN, no POSI immune RPGN. Wala tayo eh. There are no immunoglobulin or complement deposits. Okay? So, this is POSI immune RPGN. Now, most patients, this is actually a buzzword. When you see POSI immune RPGN, buzzword to. Okay? Most patients with POSI immune RPGN have elevated serum titers of your cytoplasmic antibodies or ANCA. Okay? Serum anti-neutrophil cytoplasmic antibodies. That's your ANCA. Okay? Kapag nakita nyo na POSI immune RPGN, think of ANCA. Okay? So, kapag mataas yung ANCA mo, this is also associated with vasculitis. No? For instance, your granulomatosis with polyangiitis, microscopic polyangiitis, no? But POSI immune RPGN can be idiopathic. Buzzword yan, ha? Okay? Buzzword yon. RPGN na walang immunoglobulin or complement deposit sa immunofluorescence, that's POSI immune. When you see POSI immune, ANCA. Okay? Very good, no? So, I think napahapyawan natin to with our discussion. Take a pause, take a break if you need to. Basahin saglit to, then let's move on to the next question. Okay? Now, these are the characteristics of RPGN. Okay? And pinag-usapan natin actually lahat niyan. Okay? So, ayun. Let's move on to our next question. We have a 73-year-old male that presents with chest pain. Now, we have an ECG that is consistent with STEMI. Huwag natin pahirapan yung sarili natin. STEMI na to. STEMI na to agad. Now, you did a PCI. Okay? PCI was done to this patient. Pero, okay, sige, fine. Umokay yung patient, diba? Nag-STEMI, nag-PCI, very good, nag-discharge. But this patient returned to the ER with bluish discoloration of the right toe. Okay? Tinignan mo, nag-PE ka, cyanotic yung right toe. And you have livedo reticularis. Buzzword? I think so. This is a buzzword. Okay, this is a buzzword. Pero, let's continue with our case. Kahit alam nyo na yung sagot when nakita natin yung livedo reticularis. Okay, on the right thigh. Okay? You have elevation of your serum creatinine from the baseline. 1.0 pre-op, bago siya i-PCI, nag 3.0 ngayon. Okay? Now, which of the following histopathologic findings will you see if you do a kidney biopsy? Okay? What do you think happened to this patient? No? Buzzword yung livedo reticularis, but let's discuss this formally. Okay? Let's discuss this formally. Okay. Livedo reticularis, blue toe, AKI. No, nag-AKI ba yung patient? Nag-elevate 2 days lang, di ba? 2 days lang or 2 to 3 days lang. Nag-elevate na from 1.0 to 3.0 yung creatinine niya. So, this is acute kidney injury. Okay? So, this is concerning for your atheroembolic disease. Let's write it down. Atheroembolic disease. Okay? So, yung mga invasive vascular procedures, for instance, angiography, no? PCI is angiography, no? Angiography, angioplasty, PCI din yan. Part yun ng PCI. Aortic surgery, no? Yung mga invasive vascular procedures like that can cause your cholesterol-containing debris, no? from the atherosclerotic plaque to become dislodged. Okay, pwede siya mag-embolize, no, from the large artery. For instance, yung cholesterol deposit sa aorta pwedeng masira, no, ma-dislodge during cardiac catheterization. No, pwede mangyari 'yon. So yung mga emboli na 'yon, microemboli kasi usually maliliit lang sila, they can lodge to your small and distal arterioles, particularly systemic, no, systemic arterioles. So yung mga distal arterioles na yun or end organs, no? Sa mga end organs yan magdi-dislodge. That can cause ischemia of those organs. Definitely mabablock ng cholesterol na yun yung mga organs na yun. Okay? And that develops within few days or few weeks after the procedures. So, yung skin findings, just like your livedo reticularis, blue toe, no, blue toe syndrome, those are the most common presenting signs. Okay? Now, if you do your pulses, if you check the pulses, usually okay naman sila. No, palpable pa rin naman yung pulses because again, these are microemboli and larger arteries are usually unaffected. So yung mga end organs talaga tayo. End organs, you can see we can damage the kidneys, no? We can damage the kidneys. So we can see signs of acute kidney injury. You can see azotemia, you can see oliguria. These are common, no, in the setting of your post-procedure atheroembolism. And usually your AKI can be seen in elderly patients with pre-existing renal atherosclerosis. Okay, so medyo parang alam mo yon, medyo parado na yung kidneys niya, pero babarahan mo pa. Parang ganon. That's my rationale in that. Now, if we have frank infarction of your kidneys or kidney, the affected kidney, you will have flank pain, no? Sorry, you will not have flank pain. You will not have hematuria even though frank yung infarction mo sa kidneys. Why? Because again, these are microemboli. Small lang yung emboli mo, and that's not enough to cause flank pain, to cause hematuria. No. And if you do sige, let's go to kidney biopsy. Nag-biopsy ka ng kidneys, you prepared the slides, no. Cholesterol, kasi we are talking about cholesterol atheroembolism dito, di ba? Cholesterol, if you process those slides, cholesterol is dissolved during your tissue preparation for microscopic evaluation. Now, hindi mo siya makikita. I mean, makikita mo yung kung saan originally nandun yung cholesterol, but di mo siya makikita sa slide. So, makikita mo yung frame, no, kung saan yung cholesterol. And that frame is your needle-shaped clefts, no? Ano yan, ha? High yield yun, ha? High yield. Cholesterol embolism, needle-shaped clefts sa light microscopy, no? Those needle-shaped clefts can partially or completely obstruct the arcuate or interlobar renal arteries. Okay? You can see that in biopsy. Now, again, syempre, hindi lang naman kidney yung end organ natin. We have other organs that may be involved, particularly sa systemic circulation. So, GI tract, CNS, retinal vessels, they can be involved, no, sa cholesterol atheroembolism. No? So, the answer to this question would be cholesterol clefts. Yun yung pinag-uusapan natin kanina. Needle-shaped clefts, cholesterol clefts sa arterial lumen. So, ito yung itsura nun. That this is a photomicrograph, no, of your renal tissue. So, puti na lang siya, no? Puti lang yung loob niya because again, cholesterol is dissolved, no? Cholesterol is dissolved. Puti na lang siya. Ito, yan yung mga cholesterol clefts natin. I cannot draw the frame kasi yung graphic tablet, the driver cannot be recognized. So, these are your cholesterol clefts. Okay? So, ayun, dissolve kasi siya sa paraffin embedding when you do your when pinaprocess siya sa slide. So, mangyayari yung clefts na yan, mukhang vacuoles yan. Okay? So, cholesterol clefts or needle-shaped clefts, those are high-yield buzzwords or terms pertaining to cholesterol embolism. So, yung mga ganun, vascular procedures, nagkaroon ng livedo reticularis, Tapos, nag-biopsy, may needle-shaped clefts, cholesterol embolism. Okay, that's very high yield. Let's move on. Now, we have a 40-year-old male with massive hematemesis. Okay, hematemesis. And na-resuscitate naman. Okay, nag-underwent siya ng endoscopy. Meron tayong bleeding duodenal ulcer. Akala ko ba renal tayo? Bakit biglang GI? Anyway, on the second hospital day, the urine output, ayun, renal na ulit. Urine output was noted to be decreased. Okay, you have a rise of your serum creatinine to 3.0. Baseline natin is 1.2. So, that's a significant rise. Now, this patient is at highest risk of which of the following complications? Okay? So, this is AKI. No? Acute kidney injury or acute renal failure. Bakit? Nag-gastrointestinal hemorrhage kayo. Okay? Gastrointestinal hemorrhage. That can be a pre-renal cause of your renal failure. Anyway, AKI yung pasyente. Okay. Now, if you do a biopsy, no, if for instance lang, we don't usually do biopsies in AKI. We don't do that. Okay, pero anyway, for instance, pinakitaan ka ng biopsy findings. No, biopsy findings in patients with AKI that can show epithelial necrosis of the tubules. We have tubulorexis. We can have intratubular casts that is consistent with your acute tubular necrosis. Now, in acute tubular necrosis, the injury is characterized by renal ischemia. So, in this patient, bakit magre-renal ischemia yung patient? Nagsha-shock siya eh. Nag-hemorrhage siya eh. Massive yung hemorrhage niya eh. Diba? Pwede yun. Pwede ka magkaroon ng acute tubular injury. Okay? Cytotoxicity, pwede rin. No? Cytotoxicity, pwede din. Nephrotoxins, pwede din. I remember yung mga causes ng acute tubular necrosis as a sin. Kasalanan. No? Sepsis, ischemia, and nephrotoxins. Okay? Kasalanan. Sepsis, ischemia, and nephrotoxins. Okay? Ano ba yung mga nephrotoxins natin? Yung mga contrast agents, aminoglycosides. Okay? Diba? Can cause nephrotoxicity. Anyway, your acute tubular necrosis, we have a clinical course, no? Acute tubular necrosis has a clinical course that can be broken into 3 stages. Now, those 3 stages, no? So, stages tayo. 1 is the initiation stage. Initiation stage, this is marked by the inciting event. In this case, hemorrhage, no? And that's the onset of your tubular injury. Now, if significant tubular damage occurs, the maintenance stage, that's the second stage. Maintenance. This is also known as your oliguric stage. Okay? Again, if significant tubular damage occurs, you will have the maintenance stage or oliguric stage that follows in 24 to 36 hours. Now, in the maintenance stage or oliguric stage, the urine output decreases. It makes sense, di ba? Oliguric nga, di ba? Oliguric, urine output decreases. And if urine output decreases, these patients may develop volume overload. Okay? Now, renal tubular dysfunction results in the characteristically low urinary osmolality. Okay? So, less than 350, mababa, di ba? High urine sodium. Because the tubules cannot function well. They cannot reabsorb. Di ba? Basta sira yung tubules mo. Anyway, apart from that, you can have again, ano nga ba yun? Low urine osmolality, high urinary sodium, and you have high fractional sodium excretion. Again, because your tubules cannot reabsorb. Anyway, okay? tawag natin doon, in spite of the seemingly profound damage that occurs in acute tubular necrosis, no, our tubular epithelial cells have excellent regenerative capacity. Okay, now, nag-initiation phase, nag-hemorrhage, nag-maintenance phase kasi ang sobrang lala ng injury sa tubules. Now, if the patient survives this maintenance or oliguric stage, usually by conservative management, if mag-uremia, magda-dialysis. Now, nalaglag yung pen ko. The recovery stage, no, yun follows, no, recovery stage, usually in 1 to 3 weeks. Now, your glomerular filtration rate will improve before the renal tubular function is restored. Okay, so in patients, no, 'di ba oliguric sila, pag nag-recovery na sila, they can develop transient polyuria. Kasi nga okay na yung glomerular function mo, nakakapag-filter out na ulit ng fluids, no? Pero hindi pa rin nare-reabsorb masyado ng tubules. So meron ka pa rin polyuria, no? Meron kang polyuria. So meron ka pa rin electrolyte wasting kasi ayos na yung glomerulus mo but the tubules hindi pa din. At siguro early in the recovery stage. So may polyuria ka, no? Anyway, in the recovery stage, patients are at high risk of developing clinically significant electrolyte imbalances. Okay? Clinically significant electrolyte imbalances. Particularly hypokalemia, which is the answer to this question. So, nag-ATN yung patient because of hemorrhage. We have 3 stages of acute tubular necrosis or ATN, no, initiation, maintenance or oliguric, then recovery. In the recovery phase, pwede mag-hypokalemia because again, in the recovery stage or recovery phase, ayos na yung glomerulus mo. Your glomerulus is working well, but your tubules are still recovering. You are filtering electrolytes, you are filtering fluids, you are filtering substances, pero hindi pa sila nare-reabsorb ng tubules. So you can have wasting of those electrolytes or substances, and particularly can cause hypokalemia. And hypokalemia can be life-threatening. Okay? Hypokalemia can be life-threatening. Okay? So other electrolytes like such as magnesium, phosphorus, calcium, they can also be low. Okay? So remember again, no, this is another concept na if you have hypomagnesemia and hypokalemia, you have to correct hypomagnesemia first. Okay? Or concomitantly. Because kapag mababa ang magnesium mo, correct ka man ng potassium, hindi yan magko-correct. Okay? So you have to correct hypomagnesemia. Anyway, in acute tubular necrosis, most patients recover completely with enough supportive care. Ma-initiate natin yung dialysis in the presence of uremia, particularly in the maintenance or oliguric phase. Most patients can survive this. Okay? So, this is an overview of the phases of your AKI. In this slide, 4 phases siya, pero it's okay if we understand this AKI or ATN in 3 phases, no? Kasi actually 3 phases lang naman talaga siya. Anyway, take a pause, basahin yung table, mabilis lang, then let's move on to the next question. Okay? Now, we have a 70-year-old female. This patient is a known CKD stage 4 and diabetic, no, for routine checkup. Her blood glucose well controlled naman. Now, this patient is at greatest risk for which of the following long-term, okay? Long-term complications of her kidney disease. Okay? So, in CKD, okay? In CKD, you can have abnormal bone pathology. Okay? That is known as your renal osteodystrophy. Okay? In CKD, we have failure of both glomerular and tubular function, and that can cause hyperphosphatemia. So, increase phosphorus. You can also have hypocalcemia. Now, what will happen kapag ganyan? Hindi pwede yan. Sabihin ng parathyroid gland mo that your parathyroid gland can sense these small changes, especially sa serum calcium. So, your hypocalcemia, you have CKD and you have hypocalcemia, you will stimulate parathyroid hormone production. And this is known as your secondary hyperparathyroidism. Okay? Secondary hypoparathyroidism. So, bakit hindi choice C? Long term. That's the kakainis, no? From the word lang, no? Long term, iba na agad yung sagot. It happens, no? It happens. We are training to answer questions here. Okay? It's okay, no? It's okay if you are if at this point we are getting a few correct answers, several wrong answers, or the other way around, several correct answers, few wrong answers, or perfect, or pwede ring zero. It's okay, no? Whatever the situation, forgive yourself. Pero pag, siyempre, alam mo yun, sabi nga nila, grades don't matter except pag mataas. Joke lang. anyway, let's go back to our explanation. Anyway, ang taas ng PTH mo in secondary hyperparathyroidism. What happens next? What does PTH do? Your PTH mobilizes your calcium from the bones. No? So, that this will activate your osteoclastic and osteolytic activity. So, you will have high turnover, no, sa bones natin. And this will cause osteodystrophy. And that is long term. No? Osteodystrophy. So, you will have an increase in bone resorption, more than your bone formation that can cause osteopenia. You will have pathologic bone changes, no? Pwedeng magkaroon ng this is similar, no, sa primary hyperparathyroidism. Pag sinabing primary, pinag-uusapan natin yung kanina, primary and secondary. Pag primary, mismong parathyroid yung problema. So, pag primary hyperparathyroidism, adenoma, parathyroid hyperplasia, ganon, no? Anyway, kapag naman nagkaroon ng PTH or parathyroid hormone resistance, this can lead to low turnover or a dynamic bone disease in osteomalacia. That's your tertiary na, no? Tertiary hyperparathyroidism na yon, no? And that's beyond the scope of this question, no? Anyway, deranged signaling between renal cells and osteoblasts and osteoclasts can also contribute to skeletal changes, no, in CKD, although minor, no? So, ang ano pa rin natin is your PTH, no? Increase in PTH because of your CKD. Again, let's reiterate. Now, you have CKD, sira ang glomerulus, sira ang tubules. Ang mangyayari, you will have increased phosphate, no? Increase in phosphate. You will have decrease in calcium, and decreases in calcium will trigger your parathyroid glands, no, to produce more PTH. And if you have more PTH, that will mobilize your bone calcium reserves. And pag naubusan ng calcium yung bone or nabawasan ng calcium yung bone, you will have osteodystrophy. So that's it, no? So again, no, chronic renal failure, you will have phosphate retention, you will have low levels of vitamin D. It can contribute, no. Remember that the active form of your vitamin D is the 125 form, diba? 125 form, and vitamin D is activated actually in your kidneys. Now, if you have non-functioning or low-functioning kidneys, as in CKD, you will have low levels of vitamin D, and that can cause hypocalcemia. Okay? Hypocalcemia. And if you have hypocalcemia, you will have hyperparathyroidism. And if you have hyperparathyroidism, sira ang buto. Okay? Let's move on. Now, we have a newborn that undergoes abdominal ultrasound. Then you have a kidneys, normal size, normal structure, normal location. This patient does not appear to be in distress, and PE normal naman yung no abnormalities. Anyway, pero if this patient were to be diagnosed with renal disease later in life, ano yung most likely na renal disease, no, na pwedeng ma-develop ng patient na to? Normal yung pasyente. Ang pinag-uusapan natin is theoretically this patient, theoretically, if later in life, anong most likely renal disease? Actually, wala sa choices, no? Wala sa choices sa sagot. That's CKD. CKD, secondary to diabetic kidney disease or diabetic nephropathy. Pero that's not in the choices. Anyway, so wala naman sa choices, huwag na natin pag-usapan. Answer to this question is actually your ADPKD or your autosomal dominant polycystic renal disease, no? So, bakit? Like other many autosomal diseases, your ADPKD manifests later in life, no? Pwede kasi magkaroon ng microscopic cysts sa kidneys that can be present at birth, but these are too small, no? These are too small to be detected by abdominal ultrasound. Now, over the years, in ADPKD or autosomal dominant, no, the cysts will enlarge. You will have pag nag-enlarge yung cysts, you will have compression of the renal parenchyma, and patients will become symptomatic later in life. Yun yung pinag-uusapan natin, later in life. So, how can we answer this question? Test-taking strategies. Cystic renal dysplasia, horseshoe kidney, Potter syndrome, lahat yan present at birth. Autosomal recessive polycystic renal disease, that's present at birth, no? Pinag-uusapan natin later in life, and that's autosomal dominant polycystic renal disease because this is for adults. Okay? Pero actually, wala talaga sa choices yung sagot. Yung pinaka-common, no? That's the CKD, secondary to diabetic kidney disease or diabetic nephropathy. So, ayun ha. So, pinag-uusapan natin here would be yung mga inborn or genetic causes. Looking at the choices. Okay? So, let's move on, no? I think that's clear. That's clear. Nakakalito. I know, nakakalito. But, at least, kaya na natin ngayon. Okay? We're training. We're becoming strong. We're becoming strong para kaya natin yung enemies. And the enemies are the questions. Anyway, let's attack this question. 40 female presents with peripheral edema and frothy urine. Alam na, frothy nephrotic syndrome, no? Peripheral edema, frothy urine. Okay, serum creatinine 1.1. Sige. Pwede, medyo elevated if ko-compute natin yung EGFR. Pero, let's not compute the EGFR. Urinalysis 4+. Taas. Madami siyang, may proteinuria siya, definitely. You did a complicated test, IgG4 antibodies. Meron tayong IgG4 antibodies to phospholipase A2 receptor or PLA2R. No, when I see IgG4, usually, ang naiisip ko dyan is autoimmune pancreatitis, autoimmune hepatitis, etc. Mga ganon. No, hindi, not autoimmune hepatitis. Autoimmune nga. Not smooth, pero kasi sa autoimmune hepatitis, anti-smooth muscle yun. IgG4, autoimmune pancreatitis na lang. Sorry, nag-ano tayo doon. Nag-ADHD tayo doon sa part na yun. Anyway, meron tayong IgG4 antibody sa phospholipase A2 receptor, and that is a transmembrane protein sa podocytes. Podocytes are part of your glomerulus, no, sa filtration. Now, which of the following is the most likely diagnosis? Okay? Most likely diagnosis. Anyway, this is definitely nephrotic syndrome, no? From the case, no? Edema, frothy urine, 4 plus albumin, definitely nephrotic syndrome yan. Pero the presence of your phospholipase A2 receptor antibodies, this suggests a diagnosis of your membranous nephropathy. Now, your antibodies against your phospholipase A2 receptor, primarily your IgG4. Okay, this can lead to immune deposition in the glomerulus. And these are thought to be a major factor in the pathogenesis of your primary or idiopathic membranous nephropathy. And primary or idiopathic membranous nephropathy is a common cause of nephrotic syndrome in adults. Okay? So, your anti-PLA2R antibodies, these are highly specific for your membranous nephropathy. Okay? If you have positive titers of this, we can effectively rule out other causes of your nephrotic syndrome. For instance, another cause is focal segmental glomerulosclerosis. So, pag present yan, yung mga antibodies to PLA2R, definitely hindi na yan FSGS. Okay? We can rule that out already. No? Hindi natin kailangan i-biopsy. We can rule that out already. Okay? Now, in addition, titers of your anti-PLA2R antibodies correlate with disease activity. Mas mataas ang titers, mas extensive yung disease. Okay? And you can do serial measurements of this. Okay? To determine if our immunosuppressive therapy is working. No? So, definitely autoimmune pa din to. So, autoimmune na membranous nephropathies, anti-PLA2R. Okay? So, how does this work? Sige, pag-usapan na natin, medyo mahaba. Actually, medyo nice to know lang naman, no? Pero anyway, how does this work? We have your PLA2R antigen that can bind to autoreactive B cells, no? And they can get internalized and fragmented through the helper T cells, through the MHC class 2 receptor. So, medyo immunology na talaga to, no? Right, definitely renal pa din, no? So, you have your T cells. Your T cells are stimulated. Dito tayo sa number 1. T cells are stimulated. Okay? Your T cells will now release cytokines. Okay? Will release cytokines. And those cytokines will feed back to your B cells to stimulate cell division, to stimulate differentiation into plasma cells. Now, you have plasma cells, you will have, ano ba main function ng plasma cells? Antibody production. Okay? And aside from plasma cells, you will have differentiation to memory B cells then. No? Anyway, these cytokines can signal different class switching and recombination to distinct IgG subclasses. And those are your IgG4. Ito siya, no? Class switching and recombination to IgG4 antibodies. Next, no? Antigen presenting cells, no? Dito tayo number 2. Antigen presenting cells can recognize your PLA2R, no, antigen, or pwedeng microbial agent through molecular mimicry. Then your antigen presenting cells, most importantly your dendritic cells, pwede ring macrophages, this will present these PLA2R fragments on your MHC class 2 molecules. Now, once your antigen-presenting cells present your PLA2R in the presence of co-stimulators, your self-reactive T cells are activated rather than rendered tolerant. And B cells are then activated outside of the follicles by the combination of antigen and T cells. Okay? Dito tayo Next. Now, after the migration to germinal centers, your B cells interact with helper T cells, leading to the proliferation and survival. Now, some of the B cells will undergo differentiation to either memory B cells, whether in plasma cells, and dito tayo ulit. No? Okay? Then, they will leave the germinal center. Okay? Now, if your regulatory T cells encounter their self-antigen sa APC, they will secrete inhibitory cytokines. IL-10, TGF-beta, no? This will inhibit surrounding autoreactive T cells. Okay? So, yon, no? Medyo komplikado, but this is only nice to know. You can skip this part if you need to, if you want to. No? Another mechanism be oxidative stress. No? Oxidative stress, this will lead to increase in pro-inflammatory cytokines, no? And these cytokines can have local effects and stimulate your resting antigen presenting cells. Now, in the pulmonary tissue, your PLA2R, no, can get endocytosed, can be presented, no, and activate your antigen presenting cells and activate your T cells and B cells, and when magiging plasma cells, magsisecrete ng antibodies, boom. Diba? That's your autoimmune mechanisms. Nag-immunology na tayo. So, this last pathology question is fairly difficult, but at least dami tayong natutunan. Okay? Now, let's move on to renal pharmacology. So, that's it, no? For renal patho. Are you okay, no? For those questions. Those are very high yield, very testable concepts, especially in the boards, no? Especially if you're a clerk, those are testable in your final exams. If you're an intern, testable din yan sa final exams, sa clerks. Sa ano bang clerks? Sa boards, no? Sa boards. Anyway, let's move on to our renal pharmacology. Okay? Now, we have a 60-year-old female that presents with lab results of elevated serum creatinine. Okay? But a year ago, normal yung serum creatinine niya. Now, this patient is taking ibuprofen for 2 weeks because this patient is suffering from osteoarthritis. Now, discontinue mo yung ibuprofen, you did another renal function test, and it returns to normal after 2 weeks. Now, which of the following best explains this patient's transient deterioration in renal function? Why? Now, this patient developed acute kidney injury, no, after taking ibuprofen. Ibuprofen is an NSAID. NSAID means non-steroidal anti-inflammatory drug. No, for ang mga NSAID natin, ibuprofen, aspirin, naproxen, no. Your NSAIDs exert their anti-inflammatory, analgesic and antipyretic activities or effects through the inhibition of your cyclooxygenase enzymes, or cyclooxygenase is also known as your COX enzymes. And COX enzymes are the rate-limiting step for the formation of your prostanoids. Prostanoids, examples niya, mga prostaglandins, thromboxanes, no? And these prostanoids are involved in mediating pain and inflammation. Aside from pain and inflammation, prostanoids, particularly your prostaglandins, they maintain and help renal perfusion. This is by dilating your afferent arteriole. Okay? Dilating your afferent arteriole. Okay? Particularly in patients with intravascular volume depletion. Okay? For instance, may congestive heart failure, may diarrhea, may excessive diuresis, no, mga ganon, or CKD, no, or chronic kidney disease. Okay? So, pag uminom ng NSAIDs, nag-damage, ang normally ginagawa ng prostaglandins is nag-vasodilate niya ang afferent arteriole. Now, you take NSAIDs, your prostaglandin production will be affected, malolower siya. If you have low levels of prostaglandins, especially in the renal vasculature, you will have impaired afferent arteriolar vasodilation. Okay? Impaired arteriolar vasodilation. So, ayun that's how NSAIDs cause acute kidney injury. Okay? Now, usually, your NSAID induced acute kidney injury, that's diagnosed incidentally sa lab tests, no? And usually patients asymptomatic naman sila. Pero definitely if hindi maagapan yung acute kidney injury due to NSAID use, that can proceed to chronic kidney disease. That's known as your analgesic nephropathy. This is because of your papillary necrosis and chronic interstitial nephritis. So yon NSAIDs can cause acute kidney injury, and if hindi maagapan, hindi natin ma-discontinue, it can proceed to chronic kidney disease. That's known as your analgesic nephropathy. Okay? So the physiology is afferent arteriolar vasodilation. So I think that's clear, no? I think that's clear. So again, normally your prostaglandins maintains your afferent arteriole to be dilated. Now, if you take a medication that decreases your prostaglandins, decreases your prostaglandin production, for instance, your NSAIDs, the maintenance of your afferent arteriole will be halted, and your afferent arteriole will not be dilated anymore. So that can cause reduced glomerular filtration rate. And if you have reduced GFR, your kidneys can suffer to acute kidney injury. And if your acute kidney injury is not it's not treated, okay, if your acute kidney injury is not treated urgently, it can proceed to chronic kidney disease. That's known as your analgesic nephropathy. Okay? I am reiterating that because that is high yield. Okay, that concept is very high yield. Okay, so let's move on to our next question. Now, we have a 59-year-old male. This is known diabetic, hypertensive, dyslipidemic. Nag-follow up sa'yo because you started new medications. But because of those new medications, you have an increased potassium and creatinine from your baseline. Now, which of the following drugs is most likely responsible for the change in this patient's renal function? Okay, which of the following drugs can cause hyperkalemia and increase in serum creatinine? And those drugs, no, are in this set of drugs choices, your ACE inhibitors. No, ACE inhibitors, yung mga pril natin. That's actually the answer, no, lisinopril. Yung mga pril natin, they are one of the most important agents in treating hypertension. This patient is hypertensive. Okay? So, hypertensive, binigyan ng prils or ACE inhibitors. Okay? One of the most important agents treating hypertension, as well as heart failure, as well as renal failure, and with or without proteinuria. Okay, so mechanism of action of your ACE inhibitors, they prevent the conversion of your angiotensin 1 to angiotensin 2. Okay, kapag nangyari to, this will prevent the efferent arteriole from constricting more than the afferent arteriole. And ang mangyayari, the glomerular pressure and GFR will decrease. Okay, so expected for the GFR to fall because again, you have your afferent arteriole, normally pumapasok yung dugo, no? You have your glomerulus and you have your efferent arteriole. Okay, now your afferent if moderate constriction of your efferent arteriole will increase your GFR. Okay? Remember, para siyang hose, 'di ba? Pag when you pag blinak mo ng konti, no, partially yung hose, 'di ba, yung water mag tataas yung pressure. Ganun din dito. Think of this as a hose, no? If you constrict this part, tataas yung pressure, i-increase yung GFR. Okay? Babalik dito, mag-i-increase yung pressure sa loob eh. Now, when you take ACE inhibitors, okay? When you take ACE inhibitors, ang mangyayari, this will prevent this constriction. ACE inhibitors will prevent the constriction of your efferent arteriole. So, dilated to, dilated din to. Now, pag dilated sila parehas, your glomerular filtration rate will be decreased. Is that clear? I think that's clear. No? So, expected, no, if you give ACE inhibitors, you will have decrease of GFR initially. And usually, this is not concerning. No? Unless the creatinine is more than 30% sa baseline nag-increase. So, that can be concerning, no? Anyway, other common side effects of your ACE inhibitors is your hyperkalemia and cough. And iba naman yung mga mechanism nun. So, remember, no, ACE inhibitors can initially decrease your glomerular filtration rate. So, ito siya, no? Ito siya. So, this is it, ha? So, ang mangyayari, if mag-dilate, no, yung efferent arteriole, that can decrease your GFR. Okay? That can decrease your GFR. So, yun. Okay, next question. We have a 75-year-old male, difficulty hearing. Okay, now, 1 week ago, this patient was admitted due to CHF exacerbation. So, we must know the drugs usually ginagamit kapag nag-exacerbate ang congestive heart failure. Now, this patient's hearing was normal prior to hospitalization. Okay, past medical history, hypertension, CHF, CKD. Now, you did physical examination, bilateral sensory neural hearing loss. Now, which of following medications most likely contributed to this patient's hearing impairment? Ba't tayo napunta sa hearing impairment? Renal yung ano natin, no? Renal yung ating module, no? renal pharmacology tayo. Paano naging sensory neural hearing loss? Anyway, definitely check natin dito sa mga drugs na to. Ano sa mga drugs nito can cause ototoxicity. Basically, yun na yun. That's how we attack the question. Which of the following drugs can cause ototoxicity? No. And which of the following drugs most likely ginamit sa CHF exacerbation? Which is definitely pwede lahat yan, no? Ginamit sa CHF exacerbation. So, we can answer this question, which of the following drugs can cause ototoxicity? And that's actually your loop diuretics, no? Loop diuretics. And loop diuretics, yan yung mga furosemide, torsemide, bumetanide. No, those are the most commonly used first-line agents. First-line loop diuretics. Especially furosemide, no? Furo sa CHF exacerbation. Okay? So, mechanism of action of your furosemide, they inhibit your sodium-potassium chloride symporters in the ascending limb of loop of Henle. But in the inner ear, meron din tayong similar transporters. And syempre, if you inhibit those transporters, you can have ototoxicity. And patients may present with tinnitus, vertigo, hearing impairment, or the worst is deafness. Okay. Now, usually, this ototoxicity occurs kapag overly dosed or higher yung dose na binigay ng mga loop diuretics natin. Another predisposing factor for ototoxicity is that this patient has CKD. Okay? CKD. So, hindi ma-clear, no, yung loop diuretic mo. hindi ma-clear. So, basically, you're overdosed. So, rapid intravenous administration can also cause ototoxicity, but hindi naman gaano, no? Or, ito pinakamahalaga. Your loop diuretics can cause ototoxicity, especially if used in combination with other ototoxic agents. What are other ototoxic agents? Aminoglycosides, salicylates, no? Aspirin, yung mga pang-inflammatory bowel disease, mesalamine, mga ganon, no? May salamin. Ayoko na. Cisplatin, no, can cause ototoxicity. Cisplatin is an anti-neoplastic, no? It's a platinum-based agent, no? Kapag pinagsama-sama mo yan, mga ototoxic agents na yan, bingi ka talaga. No? Anyway, symptoms of ototoxicity in your loop diuretic ototoxicity, impairment, no, of your hearing, but usually this is reversible, but in some cases can be permanent. Okay? Additional side effects of your loop diuretics: hypokalemia, hypomagnesemia, hypocalcemia. Okay? Basically, yung mga hindi natin ma-reabsorb, no, yung mga electrolytes and are wasted in the urine. Okay? Another side effect or adverse effect of your loop diuretics or diuretics in general is your contraction alkalosis. Okay? Contraction alkalosis is the activation of your RAAS, activation of your aldosterone or RAAS, and can cause alkalosis. So, ayan, no? This is an image of your inner ear, no? And you can see sodium, potassium, chloride co-transporters, and this can be attacked or inhibited by your loop diuretics, leading to ototoxicity. Okay? So, next question, we have a 45-year-old male, previously healthy, and nag-underwent ng elective hernia repair. And this is under spinal anesthesia. Post-op, we have difficulty voiding. You did bladder catheterization. We have post-void residual of 300 ml of urine. Now, this patient would most likely benefit from which of the following medications? Okay, so this patient is having a post-operative urinary retention. This is defined as tawag natin doon yung normal muna. Yung normal post-void urine volume in the bladder is less than 50 ml. Pero kapag more than 200, more than 300, or more than equal to 300, you have urinary or retention, post-operative urinary retention, and that occurs in up to 25% of patients after a lower abdominal surgery. Okay? Ano yung mga nagko-contribute, no, sa post-op urinary retention? It's your anesthesia. Okay? Anesthesia and analgesia. Okay? They contribute to the overdistension of the bladder, decreased micturition reflex, decreased contractility of the bladder, detrusor muscle, and of course incomplete emptying. Now, we can stimulate the detrusor muscle through the use of drugs. And contraction of the detrusor muscle can be stimulated by muscarinic cholinergic agonist. And the muscarinic cholinergic agonist of choice is bethanechol. Okay, because this improves bladder emptying in patients with post-surgery or post-operative urinary retention. I remember this as bethanechol for bladder. Okay? Let's move on to the next question. This is fairly challenging, but it's okay. Let's attack this. 45 male presents with worsening electrolyte disturbances after sustaining a head injury in a motor vehicle accident. Kala ko ba renal? Ba't naging trauma? Anyway, you did further evaluation, SIADH. Okay? Now, treatment with a vasopressin V2 receptor antagonist is started. Now, which of the following changes in plasma osmolality, urine output, and sodium excretion, respectively, will most likely occur as a direct result of the medication? So, SIADH. SIADH. Binigyan mo na itong vasopressin V2 receptor antagonists. Ano ba yun? Ano ba yung mga vasopressin V2 receptor antagonists? No? So, actually, those are antidiuretic hormone antagonists, no? Or vasopressin antagonists talaga. No? Normally, your antidiuretic hormone is secreted in response to elevated plasma osmolality. No? Elevated plasma osmolality. For instance, dehydration. For instance, decreased arterial blood volume. No? ADH normally stimulates the renal collecting ducts to reabsorb water back into the systemic circulation. Then that will lower your serum osmolality. Then that negative feedback that will lower your ADH secretion. But in SIADH, no, you have uncontrolled ADH secretion. So you will have excessive water reabsorption. Okay? Excessive water reabsorption. So this will lead to the following. 1. Low plasma osmolality. Okay? Low plasma osmolality and hyponatremia. 2. Low urine output and high urine osmolality. Okay? So, low urine output, high urine osmolality. Okay? So, ayun. Yun yung mga mangyayari. So, yun kapag may SIADH ka. Okay? Yun ay kapag may SIADH ka. Again, in SIADH, you will have low plasma osmolality. Sulat nga natin. 1. Low plasma osmolality. And 2, you will have low urine output. Okay. But if we treat SIADH with your vasopressin V2 receptor antagonist, ano ba yan? Mga Vaptans, Tolvaptan, mga ganon. No? We can reverse this. We can reverse this. So you will have increase in plasma osmolarity. You will have increase in urine output. Okay? But in urine sodium excretion, you will have no change. Kasi walang role ang ADH in urine sodium excretion. So the answer to this question is increase in plasma osmolality, increase in urine output, and no change in urine sodium excretion. Okay? So, again, SIADH, okay, you will have low plasma osmolality and low urine output. Now, if we treat the SIADH with a Vaptan, or for instance, your Tolvaptan, your plasma osmolality will increase, your urine output will increase, and so sodium excretion, urine sodium excretion will not change because ADH has no effect in your sodium excretion whatsoever. Okay? So, you can pause this video, check, analyze the image, no, the figure. This is the mechanism of action for your vasopressin and V2 receptor antagonists. Basically, you are giving more ADH, no, sa patient, no? You are giving, paano ba? No, not that. You're not giving more ADH. Sige, discuss na nga lang natin. This is the mechanism of action, no, for vasopressin and V2 receptor antagonist, no? So, we have the binding of your arginine vasopressin. Normally, no, your arginine vasopressin or your ADH normally will bind to your vasopressin V2 receptor, and this will stimulate a G protein coupled cascade. So So, yun yung mga G protein, coupled cascade, activate yung adenyl cyclase, and so on, no? And this will produce cyclic AMP, and will activate protein kinase A. So, that's basic signal transduction, no? So, because of that, signal transduction pathway, because of ADH or because of your vasopressin, this will lead to increase of exocytosis of vesicles containing your aquaporins. Okay, so magkakaroon ka ng aquaporins, no, sa membrane mo. And this will inhibit the endocytosis of the aquaporin. So, basically, paparamihin mo yung aquaporin sa cell membrane. Okay. So, increase in aquaporin 2 channel formation. Pag madami kang aquaporin 2 channels, you will have an increase in water permeability from the collecting duct. So, that's the normal function of your ADH. Now, we block that, okay? We block that effect if we give Vaptans. So, ang mangyayari, your collecting duct will remain impermeable to water. So, mangyayari, you will have increase in urine output and increase in plasma osmolality. Because hindi mo madidilute yung dugo eh. Hindi mo madidilute yung osmolality ng dugo. So, you will have increased plasma osmolality and increase in urine output if you give Vaptans. Okay? So, yon. So, that's a mouthful. Okay, that's a mouthful. You can rewind at least this part kasi pretty confusing siya, no? Especially if ngayon pa lang natin siya nahihimay-himay, no? So, that's it, no? Sige, let's move on to the next question. Now, we have a 65-year-old male that, yung cord ng mic. Hi. Ayun. We have a 65-year-old male that presents with muscle weakness and severe cramping of the lower extremities. Let's underline that. Okay, hypertensive yung patient, recently started on chlorthalidone and amlodipine 1 month ago. Did a physical exam and remarkable. Okay, now what is the most likely cause of this patient's muscular symptoms? Naging muscle tayo, renal nga tayo. It's because we are talking about renal drugs. Okay? And basically, ano ba? Basically, we are being asked what are the side effects of this medication. So actually, hindi isang medication lang, side effect lang ng isang medication. Okay? This is actually ano ba ang side effect ng iyong chlorthalidone? Okay, thiazide diuretics. Now, hypertensive yung patient, binigyan mo ng chlorthalidone. Now, thiazide diuretics, they lower your blood pressure by decreasing intravascular volume. Okay? Kasi nga, iniihi mo siya. You decrease your intravascular volume. Now, if you decrease intravascular volume, you reduce cardiac output, you lower systemic vascular resistance. Now, ano ba mechanism of action of your thiazides? They inhibit your sodium chloride co-transporter sa DCT or distal convoluted tubules. So, mangyayari, you will have decreased reabsorption both of your sodium and your chloride. So, decreased salt reabsorption basically, no? So, if you have decreased reabsorption of salt, sodium and chloride, no? Not in the salt form, no? Definitely hindi salt form 'yan kapag nasa urine. Ano 'yan? Hiwalay 'yan, sodium and chloride. Now, the decrease in the intravascular volume is partially attenuated by the activation of your RAAS. Kasi syempre, no, iniihi mo yung intravascular volume mo. Sabihin ng katawan mo, parang ang konti na intravascular volume natin. Hindi pwede yon. Activate natin yung RAAS. That's physiologic, no? That's the concept of homeostasis. Okay? Activate natin yung RAAS. Ang mangyayari pag inactivate yung RAAS, tataas ang aldosterone. Now, if aldosterone tataas, nag-increase ka ng aldosterone, this will lead to increased urinary excretion of your potassium. Okay? Potassium and hydrogen ions. Okay? Pag mataas ang iyong aldosterone. Pag mataas ang excretion ng iyong potassium, you will have hypokalemia. That's the answer to this question. If mataas ang excretion ng iyong hydrogen ions because of aldosterone, increased aldosterone, you will have metabolic alkalosis. That's your contraction alkalosis. No? When we say contraction alkalosis is a side effect of your thiazides or a side effect of your loop diuretics, that's contraction alkalosis. Okay? Clear ba how thiazide diuretics can cause hypokalemia? Clear. Okay? So loop diuretics can also cause hypokalemia. So, how I remember, no, kapag mga electrolyte imbalances sa diuretics, kapag thiazide, bagsak yan lahat. Pero, mataas ang calcium, no? Hypercalcemia kapag thiazide. Kapag loop, hypocalcemia din yan, no? So, yun, no? This is ito yung mga tubules. Ito yung tubule, no? Yung mga parts ng tubule. So, thiazide acts on the DCT, inhibits the sodium chloride transporter, no? So, pag ininhibit niya yan, hindi niya marere-absorb, andito lang yung mga sodium chloride mo. Siyempre, yung water, nandiyan din, more urine output, more urine excretion. Okay? So, that's your thiazides. So next question, we have a 40-year-old female, known type 1 diabetic with CKD stage 5 and presents to you with a CBC result significant for an increase of hemoglobin, no? Gumanda from 7.5 to 10.5. Okay, now this patient was started on hemodialysis 3 months ago with an erythropoiesis stimulating agent. Now, which of the following complications is most likely to be seen with the agent used to treat this patient's anemia? Okay, ano ba yon? Mga erythropoiesis stimulating agents. Mga EPO, di ba? Erythropoietin, darbepoetin, okay? This can be used to treat your anemia of chronic disease. Okay? Erythropoietin normally is secreted by your kidneys. Now, if your kidneys don't work, erythropoietin production is affected and can cause anemia of chronic disease. Now, how will we treat anemia of chronic disease because of decreased erythropoietin secretion? We give erythropoietin. Okay? Now, your anemia of chronic disease, usually nangyayari yan kapag less than 30 na lang yung eGFR. No? Stage 3, no? Some sources, less than 30 eGFR. In our main source, kapag sa Harrison's natin binasa yan, usually, nag-start ang anemia of chronic disease at stage 3, no? CKD. But almost universal. That's verbatim, no? Almost universal at stage 4, no? Almost universal at stage 4. Okay? In patients with anemia of chronic disease, this can lead to cardiac dysfunction, high output heart failure, di ba? Anemia can cause high output heart failure. Can cause fatigue, weakness, possible mental status changes, no? Decreased cognitions. No, now your erythropoiesis stimulating agents, they can improve anemia, okay? To avoid the need for blood transfusions or IV iron, ganon, no? Pero syempre, that comes with a price, no? With a risk. Your ESAs or erythropoiesis stimulating agents are associated with an increased risk for thromboembolic events. For instance, vascular graft thrombosis, stroke. Bakit nag-i-increase yung risk for thromboembolic events? It's because of increased blood velocity, because of the elevation of your red blood cell mass, no? So, tumadami yung red blood cells mo, definitely nagiging mas viscous yung blood, no? So, in patients being given with erythropoiesis stimulating agents such as your EPOs, they can develop hypertension, no? Hypertension because of the activation of erythropoietin receptors on vascular, endothelial, and smooth muscle cells. And the answer to this question is worsening hypertension. Okay? Now, hypertension is actually a well-known side effect of your EPO. Almost always, no, hypertensive mga patients na nag-EPO. It's more often than not because of the CKD nila, no? Hypertensive sila. Kaya worsening hypertension, lalong tumataas yung BP nila because of EPO, no? This is because of an increase in cardiac output, no? Increase in systemic resistance kasi nga nagbabind siya sa endothelium because of the increased levels of endothelin-1 and other constrictor prostanoids, no? Those are effects of your EPO. Now, besides that, EPO can affect your platelet aggregability, can affect do antinatriuresis, and can cause impaired vasodilatory action of acetylcholine. Okay? Now, the impaired vasodilatory action of acetylcholine play an important role in the pathogenesis of hypertension, no, of your EPO therapy or ESA therapy. So yun too long didn't listen or didn't read, EPO can cause worsening hypertension. So yun na lang yun. That's yun yung mahalaga. Pero if you want to dive deeper, increased levels of endothelin-1 sa endothelium due to EPO can cause constriction of your smooth muscle sa vasculature and can cause hypertension. Okay? So that's how we summarize that. So ayun let's move on to the next question. Okay, magto 2 hours na pala yung lecture. So I think will be extended for a bit. So okay lang naman 'yon, no? Okay lang 'yon. Now, we have a 30-year-old male that presents with fatigue, weakness, and headaches, no? Physical examination is significant for blood pressure of 180 over 110. Taas, no? Heart rate, okay naman. Okay, low serum sodium, depressed plasma renin activity, CT scan, we have a right-sided adrenal mass. Okay, pinag-isapan natin to kanina, yung mga hyperaldosteronism. Okay, treatment with an appropriate agent was started. Okay, nag-resolve yung symptoms. Which of the following drugs was most likely used? Ano ba nangyayari sa patient? Decreased plasma renin activity, hypertension, low serum potassium, may mass sa adrenal gland. Pag-usapan natin ito kanina. This is primary hyperaldosteronism. Most common causes, adrenal adenoma or bilateral adrenal hyperplasia. So this patient most likely suffers from an aldosterone secreting tumor or adrenal adenoma. And this leads to primary hyperaldosteronism. And the other name for your primary hyperaldosteronism is Con syndrome. Okay? So again, presenting signs of your prime hyperaldosteronism in general, no? Hypertension, hypokalemia, metabolic alkalosis. It's because of the actions of your aldosterone. Okay? And decreased plasma renin activity, no? In this patient, no, decreased plasma renin activity is due to the feedback mechanism, no? Ang dami mong aldosterone, sabi ng RAAS mo, hindi pwede 'yon. Babaan natin yung renin. Kaso it doesn't matter kasi yung mass mo, the adenoma, secretes aldosterone regardless of your renin. Okay? So, yun. Anyway, how do we treat this? No? How do we treat this? So, what is the most frequently used first-line drug? Actually, it's spironolactone. No? Spironolactone. That's a potassium sparing diuretic, no? Pero we have a newer drug, potassium sparing diuretic. Potassium sparing diuretics are also aldosterone antagonists. no? Aldosterone antagonist. So, yung kapatid ni spironolactone is si eplerenone, and those are actually the first line drugs that can resolve the symptoms of your primary hyperaldosteronism. And usually binibigay yung eplerenone in patients na hindi natotolerate yung spironolactone or yung mga nagkakaroon ng side effects such as gynecomastia, no? So, yun. Pero actually, eplerenone can also cause gynecomastia. So, pero mas mababa. 1% lang sa eplerenone pero 9% sa spironolactone. So, ayun, no? So, in my point of view dito, kita ko yung laptop, hindi ko mabasa, no, yung table, no, or yung flowchart. I cannot read because my eyes are very malabo. Wow. So, anyway, yun pa rin naman yung sinabi ko kanina. You can pause, read the flowchart, then let's move on to the next question. Okay? Sige. We have a 66-year-old male, known type 2 diabetic for 8 years. Nag-follow up sa'yo. This patient, walang gamot. Medical nutrition therapy lang. PE, significant. Yung BP niya, 140/90. Medyo mataas. Labs, increase yung albumin excretion. Okay? Hypertension, albuminuria. In addition to starting anti-hyperglycemics, kasi definitely, if you want, you would want to control the diabetes of this patient, especially kapag meron na siyang ganyang hypertension tsaka increased albumin excretion. You would want to control the diabetes of this patient with medications, no? In addition to starting anti-hyperglycemics, which of the following is the best treatment for this patient? May diabetes siya, okay? May diabetes siya, pero meron na rin siyang nephropathy. Meron na siyang increased urinary albumin excretion. Ano pa yung pwede nating isipin na meron to patient? Most probably, pag may ganyan na yan, may neuropathy na rin siya. No, most probably, magkakaroon na yan. In moderately increased albuminuria, that's also known as your microalbuminuria, that is defined as a urine albumin loss of 30 to 300 milligrams per day. And that's actually an early indication of your diabetic nephropathy. Pero yung microalbuminuria cannot be detected by your standard dipstick urinalysis. Nadedetect lang ng dipstick sa urinalysis kapag more than 300 na siya. Kapag more than 300 na yung albumin, that's already severely increased albuminuria kapag nadedetect na lang ng urinalysis. Now, if your albuminuria is left untreated, this can lead to progressive worsening of renal function. And this can lead to chronic kidney disease stage 5 or renal end-stage renal disease. Now, how can we prevent the progression of your CKD in this patient? No, progression of your diabetic nephropathy in this patient. This can be prevented by glycemic control and blood pressure control. No. In addition, progression can be slowed by the use of ACE inhibitors, which is actually the answer, no? Ang ACE inhibitor sa choices is lisinopril, no? Diabetic nephropathy can be slowed by the use of ACE inhibitors or angiotensin receptor blockers or ARB. Don't mix, no? Huwag niyong pagsasamahin ang ACE inhibitor and angiotensin 2 receptor blocker. Okay? Hindi yan pinagsasama. Magka-hypokalemia yan. Magka-hyperkalemia yan. Anyway, your early diabetic nephropathy is characterized by elevation muna ng GFR mo. Early yan. Early in the course of diabetic nephropathy, mag-increase muna yung GFR. No? Now, angiotensin 2 will further increase your GFR by selective vasoconstriction of the efferent arteriole. Now, if you want to block this action, these early manifestations of your diabetic nephropathy, you would want to use your ACE inhibitor. no, you would want to decrease that decrease that hyperfiltration, no, that's a term. You would want to decrease that hyperfiltration, no, because that hyperfiltration would progress to diabetic nephropathy. And ACE inhibitors, no, 'di ba nga pinag-usapan natin kanina, ACE inhibitors can decrease your glomerular filtration, no? And in the early stage of diabetic nephropathy, you have hyperfiltration. So you would want to decrease that hyperfiltration using your ACE inhibitors. Okay? So yon ha, let's proceed to the next question. This is actually the last one in your pharmacology. Okay, we have a 68-year-old female that presents with lethargy. Now, past medical history includes your ischemic stroke, seizure disorder, hypertension, type 2 DM, and bipolar disorder. Now, this patient responds to painful stimuli only. Okay, so medyo stuporous na siya. Labs reveal serum sodium of 118. Normal? Hindi. Normal serum sodium is 135 to 145. Okay? Now, serum osmolality ng patient is low and urine osmolality is high. Now, which of the following is the most likely cause of this patient's condition? Okay, symptomatic hyponatremia. Okay, hyponatremia. Symptomatic siya. May somnolence, may lethargy, meron kang hyponatremia, no? Serum sodium, low serum sodium. You have low serum osmolality. You have high urine osmolality. Definitely parang ang nangyayari, ine-excrete mo yung sodium mo, no? And this is very consistent with your SIADH, no? SIADH na naman tayo. Now, basically, this patient has a SIADH. Now, we can rephrase this question. Which of the following drugs can cause a SIADH? Okay? Which of the following drugs can cause a SIADH? Okay? In this case, the drug that can cause SIADH is carbamazepine. Okay? Remember, may seizure disorder yung patient. Okay. This patient can be given carbamazepine, and this carbamazepine can cause SIADH. Okay? Other medications can cause a SIADH apart from carbamazepine, no? Antidepressants, no? Your SSRIs can cause SIADH, no? Anti-cancer drugs such as cyclophosphamide can cause SIADH. Your anti-hyperglycemic drugs, no? Yung mga first generation sulfonylureas na hindi na naman natin ginagamit. Pero sige, for the sake of exams, yung mga first generation sulfonylureas can cause SIADH. Drugs of abuse, no, ecstasy can cause SIADH. Okay? So, ayun ha. So, SIADH, this is a summary of your SIADH. Okay? So, again, pause and let's move on. Okay, pause, read, let's move on. Alright? Focus tayo sa questions. So, if you reach this point, I believe pagod na yan, no? Pagod na tayo, no? Pagod na, nakakapagod, no? Nakakapagod mag-answer ng question and mag-rationalize and learning stuff. Studying is hard. Okay? Studying is difficult. But let me tell you, it's worth it. No? It's worth it afterwards. Okay? Now, in renal microbiology, no, hindi siya masyadong broad because mostly UTI lang naman pag-uusapan natin dito. No? So, if you have mastery of your UTI, no, we can ace microbiology in your renal system. Okay? So, pero definitely UTI, pero hindi lang naman UTI. Anyway, let's move on. Ito yung gusto ko sabihin kanina. Since the coverage of your renal microbiology is not as broad as your renal pharmacology and renal pathology, hindi tayo ganun magtatagal, no, with renal microbiology. Okay? So, let's move on. Now, we have a 26-year-old female pain in urination. Almost all questions dito ganyan, no? Pain with urination, burning sensation, gano'n. Sexually active, okay? Patient, sexually active. Let's underline na lang, no? Pain with urination, sexually active. Pero, protected naman. Okay? PE, suprapubic tenderness. Urinalysis, neutrophils, positive nitrite test. Okay? Urine cultures grows a gram-negative, oxidase-negative rods that form greenish colonies. Basically, identify lang natin. Microbiologic identification. Ano ba tong gram-negative, oxidase-negative, greenish colonies on EMB? Okay, so we must know first the causal organism, which of the causal organism, and ano yung virulence factor of that causal organism. Two-step question. No? Ano ba yung gram-negative, oxidase-negative bacteria that form green colonies sa EMB or eosine methylene blue agar? No? That's your E. coli. That's your E. coli. So, we can rephrase the question. Which of the following virulence factors of E. coli increases the risk of infection of this patient? No? And the answer is your fimbriae. Okay? This is also known as your uropathogenic E. coli, no? Or UPEC. UPEC. And your UPEC causes pyelonephritis, no? UPEC uses your pyelonephritis associated fimbriae. That's your P. fimbriae. Okay? Pyelonephritis associated fimbriae. That's your P. fimbriae. Your P. fimbriae is composed of glycoproteins that adhere to the urothelium, no? And that promotes colonization of the bacteria and that leads to UTI. So yung fimbriae yung pinakamahalagang virulence factor of your E. coli that can cause infection or UTI. Okay? So, my eyes, I cannot really see masyado. Sige, try natin. Anyway, sige. Tumaas yung brightness na umuna yung mukha ko, no? Gram-negative rods, okay? Gram-negative rods na lactose fermenter, okay? Gram-negative rods na lactose fermenter, na fast fermenter, andito ang E. coli natin. Okay? So, basic microbiologic identification. Let's lower the brightness. Anyway, let's move on to the next question. We have an 87-year-old female presenting with increasing confusion, lethargy. Okay? This patient has a chronic intractable urinary incontinence and meron siyang indwelling urinary catheter. This patient is febrile. Okay? Physical examination, tenderness and to the palpation of lower abdomen. Mental status examination, confused talaga, oriented only to person. Urinalysis show pyuria, no? WBC 35. Which of the following is the most likely causal organism? Take note of this. Naka-catheter siya, ha? Naka-catheter siya. So, most probably, this is CAUTI, no? Catheter-associated urinary tract infection. Okay? Positive nitrites, elevated WBC, no? Definitely, urinary tract infection talaga, tapos naka-catheter ka. This is catheter-associated. And with, meron ka ng lethargy, meron ka ng disorientation, most probably, urosepsis na to, di ba? Iisip ka na ng urosepsis. So, sa ganito, the most likely organism, no, kapag nagle-lethargy, nagko-confusion, ibig sabihin para kang ano diyan para kang may encephalopathy, 'di ba? Para kang may encephalopathy. And we can isa sa mga nagko-cause ng encephalopathy is your ammonia. Ammonia. Okay? Now, which organism, okay, which of the following organisms or choices can cause an increase in ammonia? Okay? Increase in ammonia sa katawan. Okay? The most likely organism most probably produces an enzyme called urease, which converts urea into ammonia. Okay? And sa mga organism na to, only one can produce urease, and that's your proteus. Okay? Your proteus can convert urea into ammonia. Okay? And can cause yung ating um, neurologic symptoms. Apart from that, um, your proteus can alkalinize your urine and can cause struvite stones made out of magnesium ammonium phosphate crystals, no? So ayun, yeah. This is proteus. Okay? So this is clear, and let's move on. Before we move on, management, pinakamahalaga, remove the catheter. Tapos, start antibiotics. Okay? Usually, treatment niyan, IV, ceftriaxone, or Cipro. Okay? Cipro. Okay? Sige, so let's move on. We have a 56-year-old female that presents with fever, chills, nausea, flank pain. So, parang pyelonephritis. Now, this patient has multiple sclerosis and meron ulit siyang chronic indwelling bladder catheter because she has neurologic bladder dysfunction. Now, 1 week ago, this patient was discharged from the hospital after treatment for a multiple sclerosis flare. Now, patient is febrile, may tenderness sa right costovertebral area. So, definitely parang Cauty ulit. This is Cauty ulit. Okay. So, another cause of your Cauty is your non-lactose fermenting oxidase positive gram-negative rod. Ano yun? That's your Pseudomonas. Okay? That's your Pseudomonas. And your Pseudomonas produces your pyoverdine. Okay? Pyoverdine is a pigment produced by your Pseudomonas. So, another pigment produced by your Pseudomonas is your pyocyanin. And yung dalawang yon, they are virulence factors for Pseudomonas to ensure its survival. Nag-alarm yung phone ko. To ensure its survival and proliferation, especially in iron deficient conditions. Okay? So, again, para Cauty, no? Tapos meron tayong microbiologic classification or determination. Then we determine that this is Pseudomonas. Ano yung mga pinoproduce ng Pseudomonas? Sa mga choices, ang pinoproduce ng Pseudomonas dyan ay pyoverdine. Okay? So ito, taasan ko ulit yung brightness. Gram-negative bacteria. Doon tayo sa rods, other rods. Okay? Pseudomonas is a non-lactose fermenter, oxidase positive. Okay? Okay. Let's move on to the next question. Now we have a young female, 25 female, presents with a burning sensation when urinating and increased urinary frequency. So, concerned siya about having contracted sexually transmitted disease. You did a physical examination, suprapubic tenderness. Urinalysis, negative nitrite test, positive leukocyte esterases. Urine culture shows organisms that show resistance on novobiocin on susceptibility testing. Now, which of the following is the most likely causal organism? Again, microbiologic determination or microbiologic classification. So, actually, without microbiologic determination, no, history pa lang we can answer this question. May buzzwords tayo Young, sexually active woman. Tapos, uncomplicated urinary tract infection yung features niya. Okay? So, dun pa lang alam na natin yung sagot. Pero, let's answer this question formally. Now, anong organism yung resistant sa novobiocin on susceptibility testing? Ano lang ba yung ginagamitan natin ng novobiocin na susceptibility testing? It's to determine whether the Staphylococcus is epidermidis or saprophyticus, no? So, the answer to this question is Staphylococcus saprophyticus. History pa lang. Alam na natin, Staphylococcus saprophyticus. But Staph saprophyticus is a gram-positive, coagulase negative, that is resistant to novobiocin. Okay, so that's consistent with our case, no? So resistance sa novobiocin is to distinguish saprophyticus with other coagulase negative staph such as your epidermidis. Okay? How do we treat this? Acute uncomplicated cystitis. So, usually, we can use nitrofurantoin, fosfomycin, yung mga first line natin, no? Okay? Okay. Brightness ulit because di ko makita. Okay. So, gram-positive, cocci. Okay? Pag catalase, positive, that's Staphylococcus. Pag negative, that's Streptococcus. Next, kapag Staphylococcus na tayo, we do coagulase testing. If coagulase positive, that's already Staphylococcus aureus. Now, if it's coagulase negative, we do further testing. If it's novobiocin sensitive, it's Staphylococcus epidermidis. But if it's novobiocin resistant, it's Staphylococcus saprophyticus. Okay? Okay, microbiologic determination. Let's move on. Now we have a 23-year-old, no, pregnant, G2P1, 13 weeks. May burning pain during urination. Sexually active yung patient, different male partners during the pregnancy and did not use condoms. Sige, high-risk behavior. Now, this patient, walang fever, walang chills, walang pelvic pain, PE, thick purulent discharge from the urethra. I think we know, no? We know now the answer to this question. Gram stain, polymorphonuclear leukocytes, intracellular gram-negative diplococci, buzzword, no? Now, you confirm the infection using your NAAT or nucleic acid amplification testing. Now, you do a pelvic ultrasound, okay naman yung pregnancy. Now, which of the following is the most appropriate treatment? Remember, this patient is pregnant. Okay? This patient is pregnant. Thick, purulent, urethral discharge, may PMNs, may intracellular gram-negative diplococci. That's already gonorrhea. Okay? This is gonorrhea. Now, because sobrang high risk ng behavior niya, unprotected sexual intercourse, multiple sexual partners, very high risk talaga siya magkaroon ng gonorrhea. Now, actually, a single dose of intramuscular ceftriaxone is used to treat your gonorrhea, no, urethritis due to gonorrhea. Remember, this patient is pregnant, so ceftriaxone is safe in pregnancy. Now, combination therapy, no, is only indicated if meron tayong co-infection with chlamydia, no? If co-infection with chlamydia has not been excluded. In this patient, nucleic acid amplification testing confirms infection with a single pathogen. So definitely walang co-infection. Okay? So we can use ceftriaxone alone. Pero if may co-infection, if may co-infection with chlamydia, gonorrhea plus chlamydia, we do 2 medications. No, ceftriaxone, if pregnant, we can use azithromycin. Pero if not pregnant, we can use doxycycline. Remember na doxycycline is contraindicated in pregnant women and in children. Okay? So, ayun. The answer to this question is intramuscular ceftriaxone. Sige, konting microbiologic determination. Okay. Gram-negative, cocci, diplococci. We do maltose fermentation. Kapag positive, Neisseria meningitidis. Kapag negative ang maltose fermentation, Neisseria gonorrhea. How I remember this is that Neisseria meningitidis, M for maltose. Pag Neisseria gonorrhea, G for glucose. Glucose lang yung glucose fine-ferment niya. No? So, yan. Konting microbiologic determination. Anyway, let's move on to the next case. We have a 48-year-old female, follow-up examination. So, this patient was diagnosed with overactive bladder syndrome. So, initiated treatment with oxybutynin 7 months ago, pero walang relief. Then, you inject a substance into the detrusor muscle to treat her symptoms. So, the injected substance is most likely produced by an organism with which of the following microbiological properties. So, multiple step question ulit to, no? So, you most likely injected botulinum toxin. So, 1, botulinum toxin. So, 2, saan galing ang botulinum toxin? So, Clostridium botulinum. Sorry, mga bio graduates. Na-capitalize ko yung botulinum. Botulinum. So, next, ano ang Clostridium botulinum? Ano yung microbiological properties niya? Clostridium botulinum is a gram-positive spore-forming rod. Okay? Okay, so konting insights about botulinum toxin. It's a protease, no? Botulinum toxin is a protease that cleaves your snare. Okay? Snare. Thereby, kapag na-cleave mo yung snare, you will impair the fusion of acetylcholine vesicles with the presynaptic membranes of the motor end plates. So, you will have irreversible inhibition of acetylcholine release, and that will result to muscle paralysis. Okay? In overactive bladder syndrome, so overactive nga eh. So, you want to paralyze the muscle, no, with botulinum toxin. So, if ever iniisip mo, bakit in-inject ng botulinum to? So, yun. Okay? So, it can improve the symptoms of your overactive bladder syndrome. Okay? So, ano to? Gram-positive. Tayo ulit. Okay. Gram-positive. Gram-positive rod. Okay? Non-branching siya. Okay? Non-branching. So, non-branching, anaerobic Clostridium. Okay? So, ayun. Gram-positive spore-forming rod. Okay. Next question. Now, we have an 84-year-old female, 84-year-old male that presents with left flank pain, bloody urine. Okay? PE, meron kang left costa vertebral angle tenderness. Now, urinalysis, pack-filled RBC, microscopic analysis, may stone tayo na merong magnesium ammonium phosphate. Now, which of the following is the strongest risk factor for this patient's condition? Okay? So, ano to? So, this is actually an infection, no? An infection. So, UTI. Anong infection yung magkakos ng ganito? No? Anong infection? So, UTI caused by your proteus. No? Caused by your proteus. And proteus, again, has a urease. Urease can cleave your urea into ammonia and can alkalinize your urine. And if your urine is alkalinized, you can have stone formation. Okay? Stone formation. And with stone formation, you can have nephrolithiasis. This is actually nephrolithiasis. Okay? So, UTI caused by your proteus. Okay, now we have a 6-year-old male that presents with dysuria and increased urinary frequency. Then we have urinalysis, cloudy red urine. Now, this patient's clinical presentation is explained by an infection with a virus with which of the following features? Dysuria, increased urinary frequency, bloody urine. These signs and symptoms suggest acute hemorrhagic cystitis. And isang virus lang, iisipin natin when we see hemorrhagic cystitis. Okay? Those are your adenoviruses. Adenovirus. Okay? Now, adenovirus, anong characteristics nila? They are non-enveloped with linear double-stranded DNA. So, that's actually the answer to this question. So, ano pa? Ano pa yung mga, ano niya? Ano pa yung mga characteristics niya, aside from the DNA, adenoviruses have an icosahedral capsids, no? Yung mga serotypes na 7, 11, 21, 35, nice to know, no? They cause, ito yung mga serotypes na nagkakos ng viral hemorrhagic cystitis. And most frequently among male children. Okay? Male children. Okay? Other associations sa adenovirus infections would be febrile pharyngitis, pneumonia, conjunctivitis, gastroenteritis, and myocarditis. Okay? So, classification of virus. So, maganda, DNA versus RNA virus. No? So, in DNA virus, we can classify that into double-stranded and single-stranded. Double-stranded, we can classify that into envelope and unenveloped. So, ito sila. Envelope double-stranded DNA viruses, your HEPA-DNA virus. Ano na kinokos niyan? Hepatitis B. No? Herpes viruses, and pox viruses. Okay? Pox viruses, molluscum, no? Yung mga molluscum natin. Unenveloped na double-stranded, that would be your adenoviruses, pag-usapan natin kanina. So, papilloma viruses and polyoma viruses. Okay? Polyoma viruses. Yung mga JC polyoma virus, mga ganon. Pag single-stranded na unenveloped, that would be your parvoviruses. Parvovirus B19, slap cheek, no, sa children. Kapag sa adults, arthritis. Okay? RNA viruses, okay, so, pwede siyang positive sense, negative sense, positive via DNA kasi reverse transcriptase, or can be positive or negative, no? So, positive sense, pwedeng envelope or unenvelope. Pag unenvelope, ito yung mga calicivirus and picomavirus. Envelope, coronaviruses, yun, ang ano natin. Coronaviruses, flaviviruses, togaviruses. Okay? So, kapag negative sense na RNA, we have, lahat yan envelope. So, arenaviruses, bunyaviruses, filoviruses, orthomyxoviruses, paramyxoviruses, rhabdoviruses. Pag mga either, no, positive, negative RNA, double capsid yan, those are your reoviruses. And reverse transcriptase, retroviruses. Envelope yung mga yan. Okay? So, next question. We have a 49-year-old female that presents with dysuria, urinary frequency, malaise. No? You sent a urine sample for culture and sensitivities, and meron tayong E. coli. Okay, sorry bio graduates. No, dapat small to. Which is resistant to ampicillin. What is the mechanism of resistance? No? Most common mechanism of resistance ng E. coli would still be your beta-lactamase production, no? Okay? So, beta-lactamase production, ang ginagawa ng beta-lactamase is it cleaves the beta-lactam ring of the antibiotic, rendering it inactive. Okay? So, ayun. This is fairly easy recall, no? Most common mechanism of resistance. Okay, last question. We have a 17-year-old female, may urinary frequency, urgency, vaginal discharge. Okay, sexually active, multiple partners. Now, which of the following additional findings would be most specific for pyelonephritis? Okay, so women, okay, are really more susceptible to urinary tract infections because anatomic position of the urethra, it's really closer to the rectum and it's shorter, no? Sexual intercourse is often a precipitating factor for UTI. So, urethritis and cystitis, they are both characterized by dysuria and frequency, urgency, pyuria, and bacteriuria, but suprapubic pressure and tenderness is more specific to cystitis. Now, if pathogens ascend via the ureter to penetrate the kidney parenchyma, symptoms of pyelonephritis, fever, chills, nausea, vomiting, flank and abdominal pain, costovertebral angle tenderness, they can develop, no, pag nagpyelonephritis. Now, if you do urine sediment microscopy sa urinalysis, magkakaroon doon ng white blood cells, white blood cell casts, and bacteria. Now, pyuria and bacteriuria, they are also found in infections of the lower urinary tract, but WBC casts are pathognomonic for pyelonephritis. That's actually the answer, no? In the setting of UTI. So they are only formed in the tubules where WBC precipitate with your TAM horsefall protein secreted by your tubular epithelial cells. Now, your WBC casts can also be seen in acute interstitial nephritis, which often presents with low-grade fever, acute kidney injury, pero yung mga urinary symptoms of UTI, they are not really present. So, this is an image of your WBC cast in urine microscopy. Right?